welcome to Health Impact Fall. We're excited today to talk to you about personalizing digital health through adaptive patient-focused digital front doors. And I'm counsel in the Healthcare and Life Sciences group of Latham & Watkins in the Bay Area offices. And I generally advise companies operating in the healthcare industry on healthcare regulatory and data privacy and security matters. Now I'm going to introduce you to the rest of our panel.
Hi, everybody. So my name is Matt Fisher. I'm general counsel at Carium. We're a virtual care platform company really focused on driving patient engagement and remote monitoring.
Great. Mark, how about next?
Mark Hanson, I'm the CEO of Decoded Health. We are a clinical hyperautomation company. We are solving the problem of the labor shortage in healthcare with respect to physicians and clinicians by automating clinical tasks.
Great. Laird?
Hi, my name is lairdmita. I'm the Assistant Vice President of Physician Contracting and Ambulatory Financial Operations for North Bay Healthcare, which is a small nonprofit hospital system in Fairfield and Vacaville, California. My team and I are heavily involved in the provider relations and provider solutions in general, and many of those now include technology solutions, both patient access to our systems as well as provider capacity, through technology.
Great. And Jason?
Hi all, I am Jason Wells. I serve as the Chief Strategy, Consumer and Innovation Officer for Adventist Health. We are a 24 hospital system and hundreds of clinics up and down the West Coast and Hawaii. And part of our 2030 strategy is to have 50% of our visits and care moments and be virtual digital by 2030. And so big lift.
Great, thank you. Well, I thought we would start today. We have a lot of interesting things and topics to cover here, but I thought we'd start just talking a little bit about some of the regulatory changes we've seen in this landscape, sort of in the past year or so. And I think, sort of at a high level, generally what we're seeing on the regulatory front is that there's a general relaxation of requirements, really to allow for the coordination of care and data sharing for those purposes. And we're seeing what the agencies are calling a regulatory sprint. And it's really a coordinated effort to, remove barriers to innovation, to provide flexibility for coordinated, cost-effective care. We're seeing incentives to transition from volume-based to outcomes-based care, and really at its crux, outcomes-based care is about sharing information so providers can coordinate care to, manage populations of patients. The CMS calls it a three-part aim: better care for individuals, better health for populations, and lower cost. And so on this, sort of healthcare regulatory stark anti-kickback side, we have, value-based arrangement rules, and, those are applied to all payers and really are, providing greater flexibility with the more, the greater assumption of financial risk. And then we have, on the HIPAA side, there's been a regulatory emphasis on patient access to care and patient-directed data sharing. And also, an emphasis on care coordination. And so that providers understand that, sharing information for purposes of coordinating care is permitted. And then we also, on the CMS and ONC side, we also have the final rules on information blocking and interoperability, which again are sort of aimed at sharing information and ensuring that providers are able to access information and patients are able to access their own information from various formats and so that they really can have a holistic vision of their health. So I thought we'd start maybe by talking about, we're talking about digital front doors today and kind of different innovative technologies, to coordinate care and to solve problems in the, throughout the healthcare ecosystem. I thought maybe we start with, digital front doors. So maybe Mark, you can talk a little bit about how did we, what were you, when you started with your virtual front doors, what problem were you trying to solve?
Yeah, thank you. I think it was a natural evolution, and we see these kind of moments in the history of healthcare that pull forward maybe a decade technology adoption into a very small amount of time. We saw that with the HITECH Act and the adoption of electronic medical records. I think COVID pulled a lot of digital engagement technology into healthcare very quickly, just out of necessity. At the beginning of COVID, people were very reticent, as everyone knows, to go to the doctor, and doctors needed to quickly find a way to engage with their patients virtually and digitally. And the solution there was telehealth. And we saw telehealth as a technology. You know, people were using FaceTime for telehealth or using Zoom for telehealth. But it was very much a single point technology that wasn't really a workflow that was very efficient. And so what we've seen with digital front doors is an amalgamation of different technologies that start to create a patient consumer experience that really is a digital first experience that enables omni-channel care ultimately, whether it's going to be a telehealth encounter or actually going to the correct line of service physically within the clinic or hospital. So what we've seen is, you know, the quick adoption of telehealth, but then also a fast follow to many more technologies that automate a lot of that workflow that otherwise would have taken place in the clinic. Things like scheduling, registration, determination of benefits, collection of copayment. Everybody seems to do it slightly differently, and there isn't really a single source solution. So you need to bring a lot of different technologies, APIs, integrate them together to create an experience for your patients that not only works for the patients that want to have care at home, you know, either beginning their encounter or their journey through the healthcare system, but also those patients that are returning home and extending the capabilities of the hospital to the home and to where that patient resides. That takes a lot of technology to accomplish, and that's what we're seeing hospitals really embrace very quickly as a virtual front door strategy. With that, it brings, you know, new problems, of course. You know, I have a friend who says that maybe virtual front door was like adding the drive-through to the Starbucks. We've created convenience, and we've also probably increased demand quite a bit because we've increased access, and we know that when we increase access and convenience, demand increases as well. But we haven't exactly enabled ourselves to make more coffee. And so we start to see the limitations of our workflow in other areas, particularly on the clinical side, where now we've got bottlenecks, not at the front of the experience, but maybe midway and at the end of the experience, where the physician, the nurse starts to become the rate limiting resource with respect to providing care. And I think that's where the virtual front door is evolving, is very much into creating efficiency, because telehealth is still, relatively high from its baseline prior to COVID, and now volumes are coming raging back to clinics and health centers. So we've got to be able to tackle that demand in an efficient way.
Yeah, and I know that, maybe Jason or Laird, I know that you have a lot to add to this in terms of what you're seeing kind of on the, once you get past the virtual front door, how you're trying to solve for efficiencies there as well.
Yeah, I'd put an exclamation point to everything Mark just shared. He absolutely nailed it. So our volumes, we've seen that the pandemic accelerated the opportunity to go digital. Physician adoption went through the roof because it was the only way to continue to see their patients. And so they adopted things that may have taken years to really motivate and kind of bend that curve. So what our challenge has been is that same thing. How do you provide a touch-free clinic experience? How do we allow people to sign their consents, on their phone and look at their health history and see if anything's changed and be able to walk into that clinic experience right from their car, skip the waiting room and go right in. So you can imagine the operational challenges with one getting that right. And as Mark shared, there's no partner that has the entire continuum of care digitally. We partner with about 12 different entities in that space through APIs, and it has to be seamless for the consumer. We haven't figured that out yet. And you don't want the consumer to have to download 7 different apps. And it's, one thing Disney does so well, it's this coordinated experience. Or Marriott, you've got the Bonvoy app, and you don't have to go to a different vendor to use your phone to get into your room. It's all through Marriott, but clearly Marriott didn't develop a lot of those technologies. So on the health system side, we have to make it seamless for the consumer. I started using things like Grubhub and DoorDash for the first time through the pandemic. And, when you're stuck at home, you're willing to start downloading some different apps and trying some things that may have taken years to try. Healthcare consumers are now in that same mindset. They're very comfortable in the digital space. And they're like, why haven't you guys caught up to the rest of the world? And they're holding us accountable. And they're frankly moving with their feet to healthcare providers that have figured this out. And so it's essential for all of us that we get on this digital journey and do it quickly and do it well, frankly.
Yeah, I guess I'll chime in there because I agree with what you said, Jason. And Mark, and what we've noticed at my company is we've seen that evolution of thinking occur over the past 12 to 18 months where, kind of Mark, as you said, it started with, we just need to throw something out there because we don't have any tools to actually connect with our patients. They can't come in to, okay, now that we have these things in place, we just threw them together. They're not maybe fitting together. How can we evolve that? And, we've seen that working with some of our customers where, I think maybe a first use case had been, okay, we're just going to do the remote monitoring, but then seeing how you can drive engagement, it evolved into that digital front door where you kind of have some of that throughput that you're talking about, Jason, of, we always constantly hear from systems and others, like, we don't want to keep adding apps for our patients. We just want to make it easy for them. And when you can find something that you can scale off of where you have a solid base and can keep putting additional components in, but not changing that end user interface, we've seen a lot of power and a lot of sustained uptake with that.
Yeah.
I agree with pretty much everything that's been said so far, and it's very well put. The notes that I wrote down was, we've kind of figured out this is what we need to solve for. We've also sort of figured out what the technology is that needs to get there. The area that becomes a bit more challenging, that at least for me in my experience, was the implementation, integration, and adoption, right? So how do we implement this the right way, right? I think Jason talked at length, about that. And then how do we make sure we integrate with our legacy EHRs and other technology solutions that we have, right? And then is it being adopted properly? Not just by the, by the patient, the consumer, but also by the staff, by the providers, and all that. In the provider realm, one of the things that I have to always constantly, in a way, apologize to doctors is the burden that they have when it comes to the technology pieces they are constantly need to adapt, and also the as far as documentation, all of those, it's an increasing burden that's placed on the providers and on the support staff. And so I think technology needs to take those areas into account as well. Sure, let's open up the front doors for the patients, but then how does it flow downstream from there? Are there areas where AI can automate a lot of the things, like Jason said, to where you go from your card to, to the exam room? Without having to, and then when the medical assistant or the provider comes in the room, they already have your medical history. You've already answered the questions. And I think those are huge pieces, and also alleviate the burden on the provider so that they're not spending, 5 to 7 p.m. every day, completing their notes because there's just so much, documentation and emails and inbox that they have to manage. So
that is a great point. We in Adventist Health, I know we have around over 800,000 care gaps left open right now: mammograms, colonoscopies, annual wellness exams. And so you can imagine the amount of front desk, back office staff it would take to one, get someone to answer their cell phone to close those. So what exists out there to be able to appropriately, in a safe and HIPAA compliant way, reach out to those, let's say 800,000 patients to say, hey, you haven't had your mammogram in 4 years. Can you click here to schedule that? And what can we do to do that through AI and make it seamless? Because we have a moral obligation to help people find the cancers that they have in their bodies. And if we aren't, we're not living up to our mission. And it's a serious challenge when you can't get MAs because, you get how hard it is to get RNs and MAs right now. You can't go hire more staff. So we have to have the technologies to help us close those gaps.
And I think,
Jason, I think to your point, it's, it's also having the different kind of forms of communication to reach out, because we've seen with some of the some of the customers we're helping, they'd say, well, phone call is not going to do it, so we want but when they text somebody, all of a sudden they get an instant response. And like we had one example where a new customer sent out a text to a patient to get them enrolled in RPM, and within 5 minutes of sending the text, they already had exchanged texts back and forth and had an appointment scheduled, where the practice before that had been trying to call and was not getting any type of response. So it's, being able to meet the patients exactly how they want to be met. So, some people do like the phone or maybe an email, but text and that type of form of communication is definitely growing, and one in an area where I think it's not sufficiently utilized.
Yeah, and I would just say in the text message, I know we get a lot of questions on the legal side because it's something, as the sort of information is trying to be sort of, communicated in different ways in text message, you have things like the TCPA, and there are certain exceptions, and that's TCPA is constantly evolving, and it's very litigious. So I have 2 questions right now about text messages and kind of the guardrails on what can we put in the text message, what constitutes consent for that text message, and kind of, just sort of those kind of careful steps before you start a campaign, I think are so important. And especially in the healthcare space where, for the most part, you're trying to engage for healthcare purposes. You're not, it's not typically marketing, but even that, I think you have to be really careful because, the difference between an informational and a marketing text is not always as clear as you would think, and it is something that plaintiffs' attorneys love to sort of latch onto. So it's something that I know we get questions about all the time, and it's constantly evolving. There's new TCPA, cases coming down there's sort of recently and very often. So it's something that we watch carefully, and I think the more that it becomes kind of patient engagement and patient access and the more that that's a focus, I think the more sort of careful we want to be with respect to those communications. And I guess kind of on those lines, I think, from a regulatory perspective, there's so many sort of interesting things to talk about and think about when you're, implementing these innovative technologies. And I think, from a legal perspective, there's we're thinking about things like, physician oversight when we're thinking about AI and machine learning, and we're thinking about scope of practice, what exact, and I think really having that physician in the loop at all times and having that oversight. And then, we're always thinking about data issues, both on the healthcare provider side, the health system side, and then also, for our technology companies and clients, we want to think about, make sure that they have the data they need to train their algorithms. Thinking about it in a HIPAA context, it gets increasingly complicated when, you have apps that patients are engaging with, and you have a certain consent there, and you have your terms of use and your privacy policy, and you want to make sure that that is governing, and that's very clear in your, if you're for the technology, on the technology side, you want to make sure that that's clear in your agreements with the healthcare systems. And, and then of course, healthcare systems, we're always thinking about HIPAA and privacy, and we want to make sure that, we strike the right balance there as well.
Hey, Heather, if I could add one more to your list there that I kind of ran into was
Sure.
a site of service. How do you define site of service for virtual care? Especially if the provider is not in the clinic, they're doing it from somewhere else remotely. Can they do it remotely? Do they have to be in the clinic if they're going to do virtual care? And the patient obviously is not there. So it was an interesting thing we had to kind of ask questions about too, like how do we define site of service now for the purposes of provider enrollment with Medicare and health plans and so forth. So one more thing to your list.
Yeah, no, great.
And I'll even add yet another one to it, which is something that will theoretically end maybe early in 2022, but the impact of all the waivers as a result of the public health emergency that came into play when COVID was, arose. I think we're probably all familiar with the fact that all those waivers greatly expanded the capabilities of what could be done through telehealth, or really kind of any of the various iterations that can come in. And I know, like at Carium, we get questions from our customers of, well, can I, how many days do I need to do for monitoring, or how can who is eligible for it, and there's still that interplay with the waivers, and people forget that those have established almost that new reality, and that a lot of it is still going to roll back when the public health emergency ends. With all the fee schedules coming out this first week in November, I think that's providing hopefully a spur to Congress to kind of keep that ball moving forward, because CMS and HHS keep saying we're going as far as we can without legislative change. And I think that keeps getting lost because there are so many other things that are coming up from a policy perspective. And I'm really fearful that we're going to come sometime in the first or second quarter of 2022, because the public health emergency is going to have to end at some point. And overnight, we're going to go back to a world that no one wants to come back into play.
Matt, I think that's brilliantly said, because that would be the challenge. Physicians and clinics have adopted this new reality, and many are finding it more efficient. Their patients are absolutely loving it. And we've got to be ready to roll back all the things that the PHE did that are not allowed moving forward. But when it's built into the core of your operations, that's going to be the big challenge. Is they're like, no, I love doing this. Well, when Adventist Health, 82% of our payers are government payers, we're going to follow the rules, and it's going to be hard to take some of these tools away from physicians if we don't have some of the regulatory changes to support the efficiencies we found.
Yeah, and I mean, it's hopeful that, sort of the focus on patient access to healthcare, to information will sort of help move this forward even after, the pandemic ends. But yeah, it is something, that we have to be really mindful of and watch really carefully. Well, I think kind of thinking through sort of some of the challenges and ways in which we can kind of promote these technologies. And maybe we can hear from, Matt or Laird or Jason on how health systems can support both, on-demand and asynchronous communications with patients without overburdening clinicians.
Yeah. I think that is huge, right? So, I think Mark said it, Jason, Matt, they said that, look, we opened up the doors, now there's more patients, but, how do we not we've already overburdened, all of our processes, all of our operations. We've stressed them to the limits now because we've created new type of access. This is sort of like the Uber effect. Not many people took cabs before Uber existed. All of a sudden, as soon as Uber existed, everybody is doing rideshare. So it's the same thing here. Now that you provide this virtual care solution to patients, they're going to use it. They're going to use it more than before. So it is by nature created more volume of work. So, one thing that we have, I'll be very honest, it's a patchwork right now. We've got a solution for this particular service here. We've got another service line that has a different solution. So we've tried, in a lot of these kind of were grassroots. They started from the from the teams that needed solutions right away on April 2020 to start seeing patients. So individual service lines reached out and figured out solutions. But now the question is, how do we do it from a system level and do it better? We've got a lot of options now. So I'll give you an example. We've got an urgent care partner. They are fantastic at doing the front end, especially, but the back end too, when it comes to care coordination after the visit, of the patient. But even before, from the time when the patient is scheduling their appointment to the time that they're in the exam room, a lot of that can be done via their mobile phone. It's all in the app. All the questions, you're getting 20, 30 questions, and depending on what you're answering, the algorithm will ask you one more question and one more question. And I've seen the physicians would design the solution they wrote all of the things that they need to know as physicians before a patient is in the exam room, right? So I'm going back to Jason's point to where you go from your car to the exam room, right? So this is launched right now in our urgent care platform. It is great. We don't have this in our other services. How do we go about getting in other services? And another thing is this urgent care solution has a different EHR than the rest of our system. So how do we go about integrating, all this documentation, all these medical records now to our legacy EHR? So those have been sort of like some of the real experiences that are, that I've noticed, in our organization. And that's one example. Other examples are creating telemedicine solutions for our hospital-based physicians, the hospitalists, the ED doctors, the intensivists. How can we have more physicians when we have a surge on the inpatient side that we need more doctors to help out? How can we get more physicians without really, adding more bodies on the floor? Because number one, we don't always have that option. We don't just have another doctor to come in. And second, it's very expensive. So, that's another area. It's a little bit different from the front door side, but it is another provider capacity area that we've kind of started going down that path as well and finding solutions.
Yeah, Laird covered it well on the provider capacity. And so we found a partner on the behavioral health side. And if you think about the traditional model of, a patient might be with a psychiatrist, psychologist, LCSW, 50 minutes once a week. They have the Tuesday at 3 p.m. appointment. We know in behavioral health, that's not the best strategy, because it may be Thursday when they really actually need that support and end up in an ER on Friday, and they can't wait till that next Tuesday appointment, but that LCSW is completely booked up. So what can we do from an asynchronous standpoint? So this partner has been incredibly successful with a bot, Carla. And Carla has regular conversations with all the patients in the panel and can escalate things based on the feedback through Carla. So it's leveraging, scaling the small amount of clinicians that we have, but it is that 24/7, 365 connection. And yes, it's through a bot, but it's a smart bot who can escalate things as necessary. And then you have an on-call team that can step in and help out. And I think we're seeing a new breed of clinicians that are really enjoying knowing that they can be scaled and their expertise can be scaled. They can still have a life outside of work, but yet can truly lean in, and instead of transactional relationships, I see you every Tuesday at 3 p.m. It's an ongoing relationship that's developing, but yet it's scalable. So it's exciting what's developing. And again, Heather, from the regulatory side, we absolutely hope we can get the policies in place that type of relationship can continue and be reimbursed for outside of the PHE.
Yeah, absolutely. And are you seeing some physicians who are really sort of hesitant to embrace this technology? Are there some who are kind of not comfortable with it, or just see it as kind of more work for them?
Absolutely. We have to help them realize that we're scaling their expertise and then helping everyone practice at the top of their license. And so it may not be that it's the physician answering at 2 a.m, but they know they have a trusted team member that they're overseeing that is answering, and it's scaling their expertise. So you're exactly right. We don't have 100% adoption, but there is a new breed of clinician that's coming out now that is very excited about this new practice of medicine.
Yeah, no, I totally agree. What Jason said there is that it takes a long time to get everyone on your medical group, to adopt it. And so the new doctors, the new residents that we're seeing, they're far more excited about this. In fact, the solution that we have right now in the urgent cares was created by one of our own, the medical director of our ED, a fantastic emergency medicine physician who loves this stuff. And this is his creation. He started a startup company and created this product. So what I would say that I found very useful is if you have a strong physician governance and physician culture to where the physicians are included in your decision making, they will, it is a more effective way to adopt these technologies, because it's coming from physician to physician, and they're helping their peers, if you will, to jump on this new technology. That's been far more successful for us than just having an administrator or an IT expert to go and teach a physician, here's how this technology works. So I found that a strong physician culture and collaboration has been very, very useful.
I think also there's a couple frameworks that are a bit helpful in looking at how you roll out and deploy these technologies. The first one is augment versus automate. So when you look at your clinical workflow, look at where the inefficiencies are and say to yourself, am I going to automate that function, or am I going to augment the person that's performing that function in order to get that workflow done? And to the extent that you do automate, I think it's critically important. This has been a learning for us, is that you can't take people's jobs away from them and expect them to still be there and not have a job to do. So, very much you have to, when you're recontextualizing somebody's role, it's very important that to know that they're going to embrace the technology if they feel that they have a new job or new objective that might change because you're automating a task that they previously performed. So if you've got a registration clerk at your front desk and you've got an automated check-in system, you really need to think about how you're going to reutilize that human resource in your front office, because otherwise your technology adoption might not go so well, because that clerk is not going to be incentivized to point people to the automated workflow. The second thing is that a lot of times we get down to, particularly on the Augment side, not only what is the task, but what is the knowledge that's required to perform the task. And ultimately, working at top of license, you get to kind of ascending orders of complexity and the amount of knowledge that's required. And ultimately, it's going to be a clinical decision that's made. And that's that clinical knowledge, that medical expertise is going to be the rate limiting resource. And so how do we support physicians? And I think a useful tool is look at the things that physicians utilize today that make them efficient that aren't necessarily AI. A great example is scribes, right? So scribes do the documentation in some part for the physician. We know that scribes, human scribes, can increase productivity for physicians by 20%. Unfortunately, we need kind of a step function in productivity. We looked at other things that make physicians very efficient, and it turned out that physicians that supervised medical residents could see 2 to 3 times the number of patients because they had these medically trained extenders working on their behalf, collecting the HPI, doing the clinical decision making, and presenting to them not only the case but what they thought was appropriate plan of care for that patient, having gone through and interviewed the patient and looked at the patient's medical record. So we're seeing more and more clinically intelligent systems try to scale the medical knowledge and augment the physician so that they can no longer be the rate limiting step within the entirety of that patient's clinical workflow.
Yeah, and Mark, I like your discussion or you're pointing out of trying to augment what each individual is doing as you're bringing in new forms of technology. Because Jason and Larry, I agree, as you said, you have to have the clinician buy-in, but you also have to make sure you're going to the right level of the clinician, depending on what type of solution you're bringing in. Like I know when we're implementing with a lot of customers, we're kind of helping supplement like the nurses or the MAs because there's a strong remote monitoring component to it. So they're the ones who are going to be the frontline people seeing the data come back in. So we make sure that they're attending the trainings. And frankly, like I know talking with our head of implementation, what she likes to do, she gives them homework to make sure that they understand how to operate the system before it goes live. So that way they can kind of work out those bugs and not be experiencing them real time, get frustrated and want to throw out the solution because they think it's just a hindrance to what they're doing.
No, I agree with that, Matt. That's a great point. I've spent a lot of time on the implementation side, on the project management side, and I spend a lot of time in that particular piece on the training component. It is challenging. It is not an easy piece because it's going to take time you're going to need these staff to take time off of their job and come and do the training, right? So, and then you're going to have to be okay with repetition. This is not a one-time, it was taught once and that's it. This is continuous training, and you have to be patient, and you have to be okay that someone might need a little bit more time, to grasp it. And you need to identify your super users and your superstars that are much better and they can teach to others. So I had one comment also about what Mark mentioned about scribing solutions. Scribing is also going virtual. Right now, we're in the process of pretty much reviewing virtual scribe solutions because even in-person scribing, it's so hard to get right now. Our scribe partner provider is struggling to find personnel in our area. In Northern California, especially, has been especially hard to find in-person scribes, right? So even that realm, even that part of support our physicians is going virtual. So
yeah, I'll throw in a practical point on that, which might be going a little bit afield, but even in central Massachusetts where I am, the companies have trouble finding the scribes. But Lair, I agree with you. As you said, virtual is happening, but for anyone who's vetting those services, make sure, again, as we're talking about, get your clinicians involved, because I've heard about one service where it's going outside the country for the scribing to occur, which isn't necessarily bad, but then the turnaround time for the notes to come back to the clinicians interrupt their workflow, because now they're having to wait 12 to 24 hours, if not more in some instances, for it to come back. And all of a sudden you have your clinicians not liking the service that used to, as you said, with the in-person, create these greater efficiencies. Now it's actually creating inefficiency.
Yeah, Matt, I'll share one on the physician challenge side. So one of our things we've been most excited through the pandemic is in California, we've been the leader around hospital at home. So as you know, the waivers allowed, hospital without walls. And so we've cared for over 800 patients on full acute status in the comfort of their own home. And our HCAP scores with that population are actually the best in the company. But on the change management, it has been a heavy lift with physicians, because many of our 24 hospitals, the model is independent physicians are the hospitalists within our walls. And so they will have to early discharge a patient to our hospital at home program, and they personally lose those RVUs. And so, they've done the hard work for the first, let's say, 1 day, 2 day length of stay. What incentive do they have to move this patient out of the hospital to create more capacity when they've really got this patient almost ready to go home, and now they're ready for the hospital at home, but yet they're personally losing those RVUs? And so trying to show the value prop to the physician of, hey, this is really best for the patient. Let's get them out of the hospital. Let's get that patient out of the ER up to the floor, create more capacity. So it's a heavy lift to have the physicians on board with a lot of these changes. And we do believe, especially in a place like California, where it's $1 million a bed, you need to build a 100-bed hospital. It's $400 million because of the regulatory environment. So caring for patients as appropriate in their homes is a strategy that we're committed to. But that physician change management, we can't do this without physicians. Ultimately, they direct care of where patients go.
And Jason, I feel like that's the perfect argument for value-based care. And that's exactly what, they're aiming to get at, really having physicians buy in, for improved outcomes, and not thinking about, the volume, but really the value and the, that sort of improved care, reduced cost, but having, physicians share in those savings, I think is crucial. And the more we move to value-based, the more physicians will be on board.
That is a very strong and very big topic as well, right? The physician incentives, and I spend a lot of a core part of my job is to do that. And to Jason's point and challenge is that same thing here. We have that same challenge, and we've started to just shift physician compensation away from productivity. Not completely, but we're trying to make it to where productivity incentives are not a predominant piece of their compensation. It's not easy though. It's not easy. Yeah. There's a lot of, anytime that you try to attach a physician, a contract or compensation, you have to have the trust. There's got to be trust. There's got to be transparency. It has to be slow. It cannot be fast. There has to be buy-in. And so, I hear you. And I feel the challenge there.
Did you have something, Matt, on that?
Yeah, no, I think it's just kind of the additional angle to it. I agree, and that kind of underscores the difficulty of trying to shift towards value-based care while still having your kind of most of your infrastructure built around fee for service. Because, there's very few, actually, I'm probably not aware of any system or provider group out there that would be 100% value-based care. So you're always going to have some tensions. Kind of along with that, or I guess before to the next point, I agree, shifting into a more kind of base compensation and then, quality-based incentive or quality-based metrics for a component of compensation makes sense because it helps encourage to get in that direction. But at the same time, I think we also need to be honest about what the reality of value-based care is too, because I think a few years ago it was being sold as to the clinicians, you're going to have more time with your patients, but that doesn't actually bear out, because as you go more into value, you want to increase your patient panels. So now you have a larger base of patients who are still looking to access, which I think then circles back around to what we were talking about with, the virtual care, the digital solutions of, if you can drive efficiency, probably drive interventions outside of the walls of an office so you can keep people healthier, then that's going to actually kind of free up the clinicians to be practicing at the top of their license and seeing the patients who truly need to be coming in, as opposed to just trying to get people in, because then that drives the RVUs. So I think you have a lot of circular arguments and circular logic there, but I think there is a reason you start to get those self-feeding loops, because one piece really does keep feeding into the other and coming back around.
Yeah, absolutely. And maybe, I know we only have a couple minutes left here, but I don't know if anyone wants to sort of end it on a high note, kind of where, we've talked about so many sort of interesting, innovative solutions that are here now and that we're using. Anyone want to kind of chime in on what's next, where you see this moving?
We have stood up a well-being division, and we realize as we make this shift from fee-for-service to value, we as a healthcare provider have to be very good in the well-being space. And so when obviously we have margin, when we keep people out of hospitals and out of clinics and keep them healthy in a true value space. And so that is something we have to be very good at. And I'd say that would be our challenge for all health systems in the country, is we have to be experts in well-being. And as the reimbursement finally starts coming with this shift, it will be sustainable. Frankly, it hasn't been. There hasn't been reimbursement, so people haven't moved into that. But it's deepened our roots and our history as a healthcare organization. And so a lot of investment in that space and helping other health systems create well-being solutions for the communities in which they operate. So that's probably 25% of our focus, and it's really about 75% of our 2030 strategy.
Awesome. Anyone else have anything? I know we have maybe a minute left.
I think that the tools that physicians are going to be able to use to provide higher quality care to a larger number of patients and increase their patient panel size, at the same time increasing access and engagement with their patients, is going to be something we're going to see take effect over the next 2 to 3 years. I mean, the data fabric alone that we have now for patients, as interoperability and EHRs bring together a more complete 360-degree view of the patient, combined with using artificial intelligence to tell us what in this data fabric is actually important for this particular patient at this particular time, and then how do we address that patient. That's an intersectionality of infrastructure and artificial intelligence that I think is going to redefine how physicians actually perform work and the tools that they have at their disposal in order to do that.
Yeah, I wanted to add that kind of the tipping point has happened. If before it was sort of more like a choice, or, oh, let's try this, let's take our time, it happened quickly. It started in March, April 2020, and that's it. There's no going back now. So now it's a matter of how do we go about doing this, and how do we do it in a cost-effective manner, takes into account, patient care quality, service quality, financial viability, physician services, physician retention, and all those areas.
And I think the one thing I'll just add on top of that is to remember to keep the patient at the center too. A lot of what we were talking about were ways to help, improve operations within the systems or within offices, but at the same time, everything that we do should also be making patient lives easier. We don't want to be introducing something that creates friction. And I know we were talking about doing things that, some of the solutions we were talking about were definitely hitting on that point. But that also, I think, means involving patients in the discussion and not just making decisions that we think they're going to want, but actually asking the question and getting honest feedback. So that way we're not unintentionally doing something that's going to make someone unhappy and not want to come into the system and seek the care that they really need.
Absolutely. Well, thank you all. I think, we've heard so many interesting stories and perspectives, and I think, the virtual front door is clearly just opening the door to so many different innovations. And I think we're, hopefully COVID will be up behind us soon, and we will continue to see innovation in our hospitals and health systems. And And it was great. Thank you so much for all your time today. This was a great discussion.